Sorry about that. I popped on and then my fiance called me real quick and he's driving down to Columbus, so I wanted to make sure he was okay.
No, that's okay. Let me fix this real quick. This is your code to get in. I won't do land school for this, but I'll do it for our test when we get into our test.
Okay, so do you want me to stop sharing then?
Oh, are you in land school already?
Yeah.
Yeah, you don't need to do that for this. I'm not worried about it for this
Okay,
part.
that's no problem. All right. Oh, come on, like me today.
There'll be a couple other people popping in here shortly, so you'll see other
Okay.
people in here in a few minutes.
Yeah, that's no problem. Am I okay to start then?
Yeah.
Okay. Mute myself.
Ashley?
Yes.
See my note up here?
Huh?
I'm typing stuff to you. Did you see it?
Yeah, I saw the one.
So we're not going to get into land school air for this, so don't screw around with that.
Okay.
I'll give you the code real quick.
Okay.
Okay, I don't know if everyone's back yet or not, but I'm going to go ahead and get started so we can get some of this stuff done. We are going to start talking about diabetes now this week. So this week will be all diabetes, next week will be all endocrine everything. And then I think we start into our presentations next week. So if you have a presentation due, make sure you have all that ready to go so that we can do those. Probably what I'll do is I'll probably have like 2 parts of class. We'll meet, at 12:30 and do our thing. So right at 12:30 when we first meet, that's probably when I'll have people go for their presentations. And then, we might go over a little bit then as well, and then I'll break, and then we'll come back and we'll do the rest. So it's not such a crazy day, but that's my plan. So
I have a quick question when you're done. Sorry.
Let me see if I can get this up and going here.
Miss Silk, I have a question. Can you hear me?
All right. So with diabetes, I can get pictures off out of my way here. There we go. All right. So diabetes is the leading cause of non-traumatic amputations, blindness in working age adults, and also end-stage kidney disease. So I think you guys will kind of see a pattern as we keep going talking about these different disorders the rest of the term. It seems like almost most of the things that we talk about are all intertwined together, and one thing affects the other. So you should see that quite a bit as we keep going in some of these different topics. All right, and then this is just a basic definition of diabetes here. So this is a complex multi-system disease characterized by the absence of or severe decrease in the secretion and utilization of insulin. So there's some different risk factors for diabetes that I'm going to tell you that you can just write down in addition to some of the other stuff I have on the screen here. So if you are talking risk factors, someone who is at risk for diabetes, it's someone who is obese, someone who is greater than 45 years old, someone who has hypertension, a person with a history of gestational diabetes, or if they delivered a big baby. So even if you didn't have gestational diabetes and you delivered a baby that's like over 9 pounds, then you're at risk. If you have high density lipoproteins that are high, or your cholesterol levels really high, or triglycerides, that's going to put you at risk. And then also race puts you at risk. So African Americans, Mexican Americans, American Indians, Native Hawaiians, Pacific Islanders, and also Asian Americans are more at risk for diabetes. Okay, so the next couple slides get into a little bit about pathophys of what's going on with diabetes. So basically, you need to know that there's a certain function that insulin has. So it helps to move glucose into the cells, and it helps decrease the level of glucose in your bloodstream then by doing that. So when it moves the glucose into the cells, it's helpful for a bunch of different functions, right? So I'm going to tell you a couple other actions that insulin has as well. So not only does it move the glucose into the cell, and it does that to help you with energy, it gives you energy, but it also stimulates storage of glucose in the liver and muscle. It signals the liver to stop the release of glucose. It enhances storage of dietary fat in the adipose tissue. It accelerates transport of amino acids derived from dietary protein into the cells. And it also inhibits the breakdown of stored glucose, protein, and fat. All right, so on the slide here, again, I told you, it helps move glucose into the cells to give you energy. But it also says on here about it regulates the rate of carbohydrate metabolism. So normally your insulin level would be decreased during times where you're fasting and increased after you eat. So I don't know if you've ever heard the term prandial, like postprandial or something. Prandial means after you eat. All right, I'm not going to spend too much time on the pathophys, but basically your insulin is secreted by these certain cells in your pancreas called the islets of Langerhans. So the insulin allows the body to use these carbs more effectively for conversion of glucose for energy. You have to have adequate intake of carbohydrates, though, to be able to do all of this. So if you're someone who doesn't take in hardly any carbohydrates, you're going to have a problem. There has to be available insulin to facilitate the movement of glucose into the cells. So if you don't have available insulin, then again, you're having an issue here. There also has to be adequate reserves of glucagon. So this is released by the pancreas and converts glycogen to glucose in the liver. All right, and then this is kind of what happens so we'll get to it eventually here in the PowerPoint, but there's a point where we talk about DKA, and this is kind of what happens when that happens. So if you can put a little note in your notes here, this is what happens in DKA pathophys. So if you don't have enough carbohydrates available to be used for energy, your cells are going to start oxidizing the fats and protein stores that you have. So it's going to use the adipose tissue that it has to try and make energy from that. So the breakdown of fat results in the production of ketone bodies. And then, so you get proteins that are wasted during insulin deficiency. Proteins are broken down and converted to glucose by the liver. And then this contributes to the increase in circulating glucose then in the bloodstream. So your glucose starts to shoot up now. So when fats are used as the primary energy source, the serum lipid level also rises. So in people with DKA, you will see that. And it contributes to the accelerated development of atherosclerosis. So when you can't use this glucose for energy, from your carbohydrates like normal, the level of serum glucose will increase in your bloodstream. So you're going to start getting this hyperglycemia, and it's going to cause another thing to happen. So not only do you have, you're using your fat stores for energy and you're starting to get these ketone bodies and you're getting this high blood sugar, but now you also have an increase in this osmotic gradient. So this means that water moves out of the cells into the circulating volume to decrease the osmolarity. So remember when we talked about osmolarity back in Adult 1, we said this is the stuff that's floating in the fluid, right? So if you have too much glucose, which is our stuff that's floating in our fluid outside of our cells, there's too much glucose there, your body's trying to fix that. So it's getting all of this water to come out of the cells to try and neutralize that in a way. So now the water moves out of the cells, the circulating volume to decrease the osmolarity, and this results in an increase in urine output. So now this person has high blood sugar, they have an increase in urine output, they're using, they have the ketone bodies, they're using their fat stores for energy, and then the increasing circulating glucose exceeds the external threshold, and then now you start to see glucose spilling out into the urine. So if you did a urine test, you would see it in there. So that's kind of some of the things that happen with the pathophys there. Okay, so when someone has diabetes, typically you don't diagnose someone right off the bat as having diabetes. You have to have a few different readings that are high, to show you that yes, that's what you have going on. But some of the things that happen that are kind of clues that maybe this person has diabetes are these three P's. So we have the polyuria, the polydipsia, and the polyphagia. So polyuria, hey, it just means that you're putting out lots of urine, right? The polydipsia means that you are super thirsty. You feel like you can't get enough to drink all the time. You're just constantly drinking up a storm. And then polyphagia is where you have extreme hunger, like you're just hungry all the time. So those are the three P's, and those are synonymous with someone who has high blood sugars that might have diabetes. Now, another thing that you might see that could kind of give you a clue that maybe someone has diabetes is maybe weight loss, believe it or not. This could be a type 1 diabetic. And this is because glucose is not available to the cells and your body starts to break down your fat. And so you're losing some of your fat of your body, so it's making you lose weight. Okay, so we're going to start getting into these different types of diabetes here. Now, the first one is our type 1 diabetic. So type 1 diabetes is when your beta cells that are located inside the islets of Langerhans don't work. So your body doesn't release any more insulin at this point. So this person, because they don't have enough insulin, they don't release enough, there's not enough available to use, then this person for treatment, they need to get insulin. So typically with type 1 diabetics, this is usually a genetic thing. A lot of times people will say it's autoimmune. It has an autoimmune component. So they think, like this one thing that I have here, it says, usually your body's own immune system fights off harmful bacteria and viruses, but mistakenly, maybe in this case, it destroyed your insulin producing cells in your pancreas. So that could be a cause, you know. And then other things that people have like kind of theories about of what could cause this would be, you know, maybe you got exposed to some type of virus and that attacked these cells, or maybe it's some kind of environmental factor. But basically what you need to know for risk factors is it's autoimmune, and it has a genetic component to it. So typically people who get this are going to be young. They're on the young side. It doesn't mean everyone who you'll see that is type 1 is young, but the majority of people who get this usually get it when they're young. So a lot of times people are really thin, and this will come on suddenly. Like you don't, like with type 2 diabetes, it seems like it comes on gradually. You eventually get it, you know, but this comes on suddenly. With this, you're going to have ketones in the urine. So if you did a urine test, that would be something specific to type 1 diabetes. Okay, so then when we get to type 2. So type 2 is a lot different than type 1. So with type 2, your cells actually quit responding to insulin. So it's not that you don't have enough insulin like you do with type 1. You have the insulin there, but your cells won't respond to it. So it's called insulin resistance. So that's kind of the difference. There's two separate things that are going on with these two types of diabetes. So this leaves all the glucose floating around in your blood, and your pancreas senses this. So it releases even more insulin. And because this patient starts to experience this hyperinsulinemia, it causes something called metabolic syndrome. And so I'm going to tell you a little bit about metabolic syndrome real quick before I keep going with this. So this is in your chapter as well. So metabolic syndrome is a group of risk factors associated with the development of cardiovascular disease and type 2 diabetes. So there's four main things that happen when you have metabolic syndrome. So typically, someone with metabolic syndrome is going to have increased blood pressure. They're going to have increased blood sugar. Their cholesterol levels are usually going to be high. And they're going to have a lot of abdominal fat. And this is all around their middle. So like if you were looking at someone with this, these are typically your people who are what they call pear-shaped or apple-shaped. Like all of their fat is just right around their middle. So metabolic syndrome is linked to being overweight, and just because you're really inactive, you don't do enough to like keep that weight off. So people like this, they say you need to do aggressive lifestyle changes to help with this so that it doesn't progress into something worse. Because like I said, you can develop cardiovascular symptoms, from this. So it's a bad thing. But we mention it here because it's associated with type 2 diabetes. So anyway, with type 2 diabetes, again, it's because you have insulin resistance. And so you get this high blood sugar as a result of that. So your treatment typically when someone first is diagnosed with diabetes is diet and exercise. So they try that first. They try to get people to eat differently and to be more active to see if that will kind of take care of it. And then if that doesn't work well enough, then they'll put you on an oral medicine. The type 2 diabetic may need even more than that eventually too, because sometimes even just pills don't work well enough. Sometimes people eventually have to get on insulin as well. And then I have here too, sometimes type 2 diabetics have to have insulin because of things like surgery or stress or infection. Like I'm sure you guys have seen a patient before say, I don't understand why they have me on insulin here in the hospital. I'm not taking that at home. That doesn't make any sense. Well, it does make sense. They just don't quite understand what's going on there. So with type 2 diabetes, your big risk factors are lifestyle. Like you aren't being active enough. So typically this person's going to be overweight. They're very sedentary. They have a poor diet. They drink lots of pop and sugary type drinks. They have a lot of stress. And there is a little bit to genetics in this. It doesn't necessarily mean that everyone who has type 2 diabetes is going to pass it down to their kids, but there is a little bit of something to that. So with this person, they're not going to have ketones in their urine like you would see with type 1 diabetics. So that's something more, specific to type 1. So you will not see that here. And you know how with type 1, we said typically when you get that, you're more on the younger side. So with this, typically people are a little bit older when they get it. So, maybe middle-aged or a little bit older. Now that doesn't necessarily mean that you can't get type 2 diabetes when you're younger, because unfortunately we're such a overweight, nation right now that a lot of kids get it even because of, poor diet and poor habits and things. So it's kind of sad. All right, I also want to mention gestational diabetes. So gestational diabetes is very similar to type 2. Your cells just aren't receptive to the insulin anymore, so you eventually get really high blood sugars. So typically when someone is pregnant, they will do one of those tests, to see if you have diabetes, usually about 24 to 28 weeks, somewhere in there. So they do what they call the oral glucose tolerance test. And it's typically some kind of like drink, maybe about this big, that they make you drink over a certain period of time. Super sugary. Some of the flavors are really disgusting. But anyway, they make you drink this drink, and then they draw your blood to see like kind of how you react from this. So when someone has gestational diabetes, the worry is that they're going to have a big baby. So infants can be large for gestational age, and they can experience hypoglycemia after birth. So you're going to be worried about that as well. Also, anyone who's ever had gestational diabetes, they're going to be at risk again if they get pregnant again. So they may have it again. Also, eventually, this person is going to be at increased risk for type 2 diabetes later on in life. So unfortunately, that's me. So when I had my twins, I had this. So when I did my oral glucose tolerance test, it wasn't like super off. It was just off really slightly. And I was so ticked because I had to, start doing blood sugars and all this stuff. So it was just crazy. So anyway, they made me check my blood sugars for 4 times a day for the rest of my pregnancy. So I had to constantly be sticking myself. And then they just had me kind of watch how I ate, which was also very tricky because I was having twins and I needed more intake because of that. So anyway, I met with a dietitian and we kind of came up with a plan. So it ended up working. Like I could show you some of my records of my blood sugars, and it really did help quite a bit. My blood sugars stayed pretty good for the most part throughout the rest of the pregnancy. So I did not have to get on oral meds or insulin or anything like that, thank God. So anyway, another thing I want you to know about this, why do you guys think that this person has a problem with their glucose during pregnancy? What do you think is the link there?
Maybe the sugar goes to the baby?
Am I talking to myself, or does someone want to say something?
I mean, I don't think you can hear us.
Can you hear us? Mrs. Silk.
Can you guys hear me?
We can.
We can hear you, but you can't hear us.
Okay, well, I can hear you now. I couldn't a few minutes ago.
That was weird.
Okay, so who said something? Just tell me what you said. So I
said the blood sugar kind of goes to the baby, maybe. So like the mom loses the sugar levels to the baby. I don't know.
Anyone else have a thought? Okay, what happens is it all has to do with the placenta. So you know how your placenta is what gives your baby all the nutrients and everything. So the placenta actually produces more and more insulin, and it counteracts your hormones that raise your blood sugar. So it's all about the hormones. Like this placenta is like messing up your blood sugar from these hormones. So the minute you actually give birth and your placenta comes out, you don't have a problem anymore. So like I was shocked, afterwards, after I had my babies, they didn't even want to check my blood sugar. I thought, what the heck? What's wrong with them? And here, that's why, right? So, like my boys that I had, they checked their sugar, of course, right after they were born because they were worried that they might be low, but they were fine. So it ended up working out okay. But yeah, so with gestational diabetes, just know that it's all about that placenta, and once that placenta comes out, you don't have the issue anymore. Oh, also, just put a little side note in here somewhere in your notes about this. I just want to mention pre-diabetes. So pre-diabetes is where you're kind of getting close to getting it, okay? So I'm there, unfortunately, right now as well. So what happens is maybe you've had like a history of a couple of high readings or something in your blood work, or I don't know, you've had some other type of like random blood test or something that showed that you had a high blood sugar. So your doctor might say, okay, well, let's do a hemoglobin A1C and see where you're at. So what is a hemoglobin A1C? What does it tell you?
It's a collection of blood sugars over like the last 3 months.
Yes. So if you looked at someone's hemoglobin A1C and it was kind of creeping up there, that would be a problem, right? So for this person with pre-diabetes, typically it's someone who, when you do a hemoglobin A1C, your A1C is probably 5.7 to 6.4. So a normal person who does not have diabetes, their hemoglobin A1C is going to be lower. So it's going to be lower than 5.7. So like you might see 4 point whatever or whatever, something like that. So like for me, when they took mine, mine was like, I want to say it was 5.8 one time. It kind of hovers right around there. So either 5.7, 5.8. I've been a little bit lower than that too at times, but so it's kind of like right in that range. So they would not say that I was fully diabetic until I reached 6.4 for my hemoglobin A1C. So 6.4 is going to be, my problem area. So typically, someone who has prediabetes, they usually try to get them change their lifestyle a little bit. So eat better, exercise a little bit more, that type of stuff. So, they always encourage an ideal body weight. So they say if you can lose like 10 to 15 pounds, that can totally improve your blood sugar just by doing that. So anyway, just kind of be aware of, pre-diabetes, because a lot of people are in that boat now, and you have to kind of get them to change their lifestyle a little bit so it doesn't push them right into diabetes, because that's a horrible disease. Okay, so on our slide here, it talks about hyperglycemia. So remember earlier on, we talked about those 3 Ps, and this kind of explains what happens with each one of those. So polyuria, when you urinate too much, this tells you why right here. So I won't read that to you, but so that's that one. Then with polydipsia, you being really thirsty, this is why that's happening. Polyphagia, here's why that's happening. So I'll let you guys read through those. All right, some other assessment findings that you might see in someone who is diabetic. So a lot of times they have really slow wound healing. So there'll be times where maybe someone has a wound on their foot and they don't even realize it, because a lot of times they have a lot like less feeling in their feet. They get that neuropathy, that diabetic neuropathy, and they don't even realize. So they always tell people to make sure they really look at their feet and do really good foot care, because sometimes they just don't see some of those things happening. Other things that you might see: blurry vision. So you could get damage to your eyes from too much glucose in your system. So there is something called diabetic retinopathy that people can end up getting, and it could make you not be able to see anymore eventually. So it's a big deal. A couple other things that this mentions. It talks about an acetone smell on your breath from burning ketones in a type 1 diabetic. So if someone comes into the hospital and maybe they don't realize they're type 1 and they come in with an episode of DKA, sometimes that is how they find out that they have diabetes, is from just having an episode. And so someone in that will have this acetone smell on their breath. And then the last thing here, this talks about rashes on your skin, dry and itchy, repeated vaginal infections. This says yeast loves glucose, so you can get lots of infections like that. Okay, so then you remember we were just talking about, how do you figure out if someone has diabetes? So there's some different criteria, and this is something you definitely need to know. So you could have a fasting blood glucose level above 126. So that means that if you fasted and you didn't eat or drink anything, since the day before, Your blood glucose would be, anywhere from 126 or above. That would be a bad reading. An oral glucose tolerance test, that's like the one I was telling you about for when they test people who are pregnant for diabetes, where you like drink stuff and then they draw your blood and do all this stuff. So for that one, you would have to have a value greater than 200. And then for a random glucose, this would be like, maybe I'm in the hospital and I just did a random blood draw at 3 p.m. or something. Well, this person wasn't nothing by mouth, all day. They were eating and stuff. So this would just be a random glucose. And that would be have to be higher than 200. And then you also have to have symptoms going along with that. So that means maybe I have polyuria, polydipsia, polyphagia going along with that. So those would be some of the ways that you could figure this out. And then, of course, like we just talked about the hemoglobin A1C, that's another thing that people could do. It's not going to be completely diagnostic to say, yes, this person has diabetes. It's more of a, you suspect it from their other symptoms, so then you would run it. Another name for a hemoglobin A1C that you might see it called would be glycosated hemoglobin. So again, remember, a normal hemoglobin A1C should be between 4 and 6. Obviously, well, on my other thing, it says 5.7 as the top number, so you wouldn't want to be any higher than that. And then in someone who has diabetes, your target range is going to be a little different. So if you have been diagnosed with diabetes, they usually say they want your hemoglobin A1C to be less than 7. So they're going to expect you to be on the high side, but they want it to be less than 7. So I have this thing that I printed out that I thought was kind of cool. Let me find it here. I forget where I got this, but anyway, this is a chart that talks about hemoglobin A1C. And it'll say, okay, if my A1C is this, what does that mean my average blood sugar has been over the past 3 months? So, like, say my A1C was 6, then my average blood sugar over the last 3 months would have been 126. So that's not too bad, that's on the lower side. But I don't know if you've ever looked at someone's A1C when you have been in, clinical or something before, but a lot of times people have really bad ones. Like I've seen people at 13 or 14. So if you were at 13 for your A1C, your blood sugar over, the last 3 months would have been about 326, which is super high. So that could have been really bad. All right, I already told you about that stuff, so I'm going to flip past that. Okay, well, let's talk about, let me make sure I'm not missing anything. Hold on one second. Oh, real quick before I talk about this slide, going back to the whole diagnostics here. You know how we mentioned ketones in the urine as something that you might see with someone with diabetes type 1. So you could measure that through someone's urine or their blood. You could do either way. So it's going to indicate that there's a deficiency of insulin and control of type 1 diabetes is deteriorating. So when there's almost no effective insulin available, your body starts to break down stored fat for energy. So that's kind of what it's saying. If you see ketones in the urine, your body's already starting to break down the fats for energy, and that's a big problem. Okay, so this slide's about physical activity, diet, and stuff like that. So let's talk about physical activity here first. So it's always good to exercise, especially when you have diabetes. So in our book, it talks about, they say exercise probably 3 times a week with no more than 2 consecutive days without exercise. And then they always say, you know, how we were mentioning looking at your feet a lot. So they say for diabetics to inspect their feet after they exercise daily, and to avoid exercise in extreme heat or cold. And then they always also say avoid exercise during periods of poor metabolic control. Now this means, like, normally when you exercise, it's a good thing. It'll bring your blood sugars down. So that's a normal thing that happens from exercise. However, if your blood sugar is up, like say I'm 326 and I've been up like most of the day, if I go exercise on top of being 326, it's going to shoot me up even higher. So that's why it says to avoid exercise during periods of poor metabolic control. So it kind of does the opposite on what you think it would do. So let me kind of explain that just a little bit here. So when you exercise, when you have a real high blood sugar, what happens is it increases secretion of glucagon, growth hormone, and catecholamines. So then your liver releases more glucose in response to that, and it makes your sugar shoot up even more. So that's kind of why you shouldn't do that. The other thing to think about with exercise is, you know, like we said, normally your blood sugar would go down when you exercise. So they say diabetics should always eat a 15-gram carbohydrate snack before they exercise to prevent unexpected hypoglycemia. Okay, so it's also really important to watch your diet. And I think we're going to talk about that more on this next slide. So I'll flip to that here in a second. And then the next thing we'll get into will be some of the ways that we kind of keep control of our diabetes with medications. So with the diabetic diet, we're supposed to teach patients about their caloric requirements. We need to teach them things like how to read food labels, how they should be able to count carbs, and about exchange lists. There is an example in your book on page 1423 of an exchange list, so it can kind of give you an idea of what that is and what that looks like. Typically, diabetics are going to be on a specific caloric amount every day. So like, you know, in the hospital, a lot of times you'll see people on an 1800 ADA diet or a 1600 ADA diet. So ADA means American Dietetic Association. And so that means that out of everything that they eat on their plate, you know, throughout the day, that's how many calories they should be getting, 1600 or 1800. So you would count all of that up to see, you know, what you would get. On this slide here, it talks about the choose my plate thing that the government does, which is kind of nice because really, if you're trying to teach someone about portion control and like how much of something they should be having, this is a good visual to show people because it shows you, you know, you should have a lot more vegetables and fruits than certain other things. And so maybe a lot of people do a ton of protein instead of other things, you know. So on here, look at the protein. It's not as much as some of the other stuff, right? So it kind of gives you a gauge for, you know, how much you should be having. In the chapter in the book, it also talks about something called the glycemic index. So I don't know if you guys have heard of that before, but basically it's how much a given food increases your blood glucose level compared to an equivalent amount of glucose. So for example, if I ate a piece of toast with jelly on it that was like not sugar-free or something, how much would that be on my glycemic index compared to a thing of just plain sugar? You know, that's kind of what you're looking at there. So with a glycemic index, your main goal is to avoid sharp, rapid increases in your blood sugar levels after you eat. So you want to kind of stay even keel with your blood sugar instead of like shooting up really high after you eat. So they give you some guidelines for this in your book on page 1463 that talks about that. So on this slide, again, it gives you some guides for like how much of things you should have. So for carbohydrates, they say 130 grams of carbs a day. For fiber, 25 to 30 grams a day. And then you want to choose foods that have a low glycemic index, because then you're not going to have those sharp spikes in your blood sugar. And then the saturated fats should be less than 7% of your total calories, and your protein should be 15 to 20%. So that kind of gives you an idea of what you do with the diet. Okay, so then we get into insulin. So insulin, I'm going to tell you right now, for your test and for you guys have a quiz next week, a diabetic quiz that's worth 10 points. You have to know this stuff about insulin. This is super important. All right, so I'm going to go through the different types and some things that are important to know about them. But before I do that, I want you guys to write this down. So each one of these, I'm going to tell you an onset, a peak, and a duration. So let's talk about what those mean. So the onset, this means that it's the length of time before insulin reaches your bloodstream. Your peak, this means it's the time period where insulin is most effective. And then the duration is how long insulin works for. So when we talk about these different kinds of insulin, then you can kind of get an idea of what we're talking about a little bit more. So onset, peak, and duration, you pretty much have to memorize those for each one of these different types of insulin. So for this first one, it's rapid acting insulin. So I put the other names for it here because you need to be able to know both names. So I may not say, you know, Humalog or Novolog. I may just say Lispro or Aspart on the diabetes quiz. So you need to know both names. So with these types of insulin, this is one you would give that's quick acting. So your onset is within 15 minutes, your peak lasts 60 to 90 minutes, and the duration is 3 to 4 hours. So typically when you give this, it's going to be used in combination with intermediate acting insulin. It doesn't always have to be, but it could be. And then you're always going to give this subcutaneously. You'll never see this given any other way. So again, with these names, Lispro is also called Humalog. And then Aspart is also called Novolog. And then I also put Glucine on there, which I don't know what the other name for that one is. All right, the next one is short-acting insulin. So remember we talked about quick, and now we're at short. So short-acting insulin is just your regular insulin. So your onset is a half hour to an hour. Your peak is 2 to 3 hours. Your duration is 3 to 6 hours. So for that last one we just talked about, the quick acting, you know, if you knew someone was getting their tray at 8 o'clock, usually, typically at work, whenever I would give insulin, we would always like wait till we saw someone had a tray before we would give it, because it works pretty quickly and you don't want to give them insulin if their tray doesn't show up for an hour, because then they may have a problem. So that's kind of how we treated that. But for this one, for regular insulin, you know, your onset's a half hour to an hour. So typically you could usually give this 20 to 30 minutes before they eat. So like, in other words, if they were getting their tray at 8 o'clock, I could give this at 7:30 and I'd be fine. All right, this is used a lot in sliding scale coverage. Same with the quick acting, both of them are anymore. The routes of delivery for this one, it has two. So you can give this sub-Q and you can also give this IV. This is the only one that you can give IV. And then also regular insulin is also important because it's one that you can mix with other insulins. And you can't do that with just any insulin. So this is really important to remember that. When you see regular insulin, sometimes you'll see it as Humulin R or Novolin R. So that would be the other way you might see it written. Okay, and then this talks about intermediate acting. So the intermediate acting insulin is your cloudy insulin. So this is one that has an onset of 2 to 4 hours. The peak is 4 to 10, and the duration is 10 to 16. Hypoglycemia tends to occur in mid to late afternoon, and this is one you only would give sub-Q, and it can be mixed with regular insulin. So this is one that you could mix with that. So with intermediate acting insulin, these are often taken in conjunction with a short acting insulin because they start acting within the first hour of injecting, followed by a peak period lasting up to 7 hours. So it covers the blood glucose elevations when rapid acting insulin stops working, and usually it's taken twice a day. Okay, so then we get to the long-acting insulin. And this is one that people never remember the names of. I'm going to tell you right now, so make sure you know these names. So with long-acting, you have your glargine and your detamir. So detamir is Levemir, that's the other name for that, and Lantus is glargine. So I know most people know Lantus, but they don't know glargine. So for this one, the onset is 1 to 2 hours. Your peak doesn't have a prolonged peak. And then the duration is 24 hours or more. You cannot mix this with any other type of insulin, and usually it's given once a day at bedtime, but sometimes you'll see them given more than once a day. Detamir is the one that usually they'll do that with. That can be taken twice a day. These are only done subcutaneously, so you would never give them any other way. I did want to mention the insulin pen for a second here in case you guys would ever see that or have to give it. These are really nice, especially for people who have a hard time seeing to draw up insulin. So what happens is you get this from the pharmacy and it's already the insulin is already in here. So basically the only thing you have to do is put a small needle onto the end of this pen, and then you could give this. So anyway, let me kind of just explain what you would do with that. So with these needles, they're really tiny and they have 2 caps to them. So there's an outer cap and an inner cap. The outer cap is the bigger of the 2. And if you can imagine, just say even with your pen, so the outer cap is the one that you're going to save. The inner cap you're going to throw out. So with this needle, say this is my needle, I have a paper backing to it, on it. So I'm going to pull off that paper backing, and then you'd see the needle in here. So then it has a little twist on thing, to the end of the pen. So you're just going to twist that on to tighten it up. And then you're going to pull that outer cap off, set it aside. And then you're going to take that inner cap off, throw it out. And then the next thing we do is right at the end of the pen, there is a dial. We are going to dial this up to 2. So I'm going to dial it up to 2, and then any type of insulin pen, it doesn't matter which kind you're doing, they're all the same. So you always want to check it and make sure it's functioning properly before you give your dose of insulin. So typically they say to do an air shot. So if you draw it up to 2 and then hold it up in the air like this, and the button is right there at the bottom, so you push the button in, and then you should see a little bit of insulin come out the end. And that's going to show you that it's working properly. So then if my order was to give, 10 units of insulin, then I would go ahead and dial up to 10, and then I'd be ready to go to give my insulin. And you do it the same way as you would any other type of shot, with your darting motion to go in, subcutaneously. And then typically once it's in, you hold it there for like 10 seconds before you take it out, because that helps the insulin to absorb a little bit more. It gives it a chance to absorb. All right, we also have some complications of insulin therapy. So, you know how we always tell people to not give their insulin shots in the same spot constantly? So there's something called lipoatrophy and lipodystrophy. So lipoatrophy is a loss of fat tissue in that area. This is because you're going in the same spot constantly. So you may see like divots in their skin because they have a loss of tissue there. Lipodystrophy is where your body is unable to produce fat, and it's characterized by abnormal or degenerative conditions of the adipose tissue. So this one you may see like almost like a bump or something there. So typically you want to stay away from these places. You want to rotate your sites so you don't have any problems with your skin like this. Another thing I have on here, sometimes this is because you're giving cold insulin. So you want to make sure your insulin's kind of at room temperature when you're giving it, so you're not giving like super ice cold insulin to someone, because that could cause some of these things to happen as well. Okay, so here's what most people have trouble with. The oral hypoglycemic agents. So oral medicines, again, are typically for people with type 2 diabetes, and there's a lot of different kinds. And this is what's hard. It's hard to memorize the things that you need to know about them. So on this slide, I have the different categories of oral diabetic meds. So we've got sulfonylureas, metaglynides, biguanides, alpha glucoside inhibitors, and also thiazolinate. I can't even say that. Thiazolinate, I can't even say it. But anyway, there's, 1, 2, 3, 4, 5 different categories there. So I tried to put on the slide something that might help you pick that out in a question. So like with sulfonylureas, if you see IDES or ZIDES or MIDES, something like that on the end of a word, it's probably a sulfonylurea. So that's kind of a typical ending for those. And then metaglynides, they look like that. Glinide might be at the end, so that would be something that would, tip you off for that. So anyway, you can kind of take a look at some of these, but for your quiz, and honestly, I can't remember about the second test yet. I'd have to go look at it again to see if I asked a lot about this, but there may be some, questions like this on there where you would have to know an oral med or some characteristics of it. So just kind of look through these and see like the ones that are kind of common that you would see more often than others, and that's the stuff you need to be focusing on. So for example, metformin or glucophage is very popular, right? So it's a biguanide. So that would be one I'd probably focus on, and I'd probably try to know that. And it tells you exactly how it works there, and some other important things about it. So in your book, there is something that might be helpful. It's on page 1474 and 1475. It's table 51-6. It's an oral anti-diabetic chart. So in the chart, it'll give you like these different categories, and it'll tell you exactly how they work and some of the, other important things to know about those drugs in there. So it shows the groups of meds, their actions, their side effects, their implications. So I would definitely take a look at that. All right, so there's two kind of weird things that you might see happening with people when they take insulin. I guess I should have put this back a few slides ago, but so there's something called the dawn phenomenon, and then we'll talk about something called the Somogyi effect. So the dawn phenomenon. So this is something that happens where you get hyperglycemia in like the early morning hours. So hence dawn phenomenon, you know. So this is a time when your body increases blood sugar in preparation for awakening. However, when you have insulin problems, the increased blood sugar causes hyperglycemia. So typically you would see this happen between 5 and 8 in the morning. And basically they say, you know, the treatment for dawn phenomenon might be just giving someone a nighttime dose of NPH to counteract, you know, this happening every time in the morning. So what happens with this is during the night, you have a natural overnight release of hormones. So like we release growth hormone, cortisol, glucagon, and epinephrine. And this increase insulin resistance, causing our blood sugars to rise. This could also be associated with insufficient amount of insulin the night before. So it could be any of those types of things. All right, and then the Somogyi effect. This is more, again, it's hyperglycemia that you see, but it's more of like a rebound hyperglycemia with this one. So in here it says, remember S in the Somogyi is for sleeping hours. So this is a drop in the blood sugar, you know, in the sleeping hours, like around 2 or 3 in the morning. So this happens when your body releases those hormones again, and it causes, you know, you to have this increase in blood sugar. So for this one, you probably would want to encourage people to eat a bedtime snack and maybe have a dose of bedtime insulin to prevent this from dropping so low to where it rebounds crazy like that later on. Oops. Okay, so the next thing we need to get into is some complications from diabetes. So hypoglycemia is the one we need to talk about now. So I know depending on where you work at, a lot of times from facility to facility, they may tell you something slightly different about what is considered a low blood sugar. So for our purposes, we're going to say less than 60 is considered low. So anyway, signs and symptoms that you would see associated with low blood sugar. So this would be things like inability to concentrate, headache, lightheadedness, confusion, memory lapses, numbness or tingling of the lips and tongue, slurred speech, impaired coordination, emotional changes, irrational or combative behavior, double vision, or drowsiness. And then one that I would add to here that I guess I don't really see on my paper here would be sweating. People sweat when they have a low blood sugar. I do have it on the slide here. So that's usually one of your first things that you see to notice that there's a problem, is that they're sweating. All right, so whenever someone has a low blood sugar episode, I had this little mnemonic on here. Remember, I'm sweaty, cold, and clammy. Give me some candy. So that's typically what you're going to do. You're going to treat them. If they're awake and alert enough to be able to eat or drink something, that's what you're going to do first. However, if they are not with it enough and their blood sugar is super low, you're going to treat it differently. So we'll talk about that here in a second. But some of the things that you might do would be, you could give juice. So one of the first things we usually do is give orange juice, right? So the orange juices are, real small, so usually about 120 milliliters in them. And so you could do that, or you could give apple juice. You could give glucose tabs. If you had pop, you wouldn't want to give a whole can of pop, but maybe like 120 milliliters or so would be okay. Yeah, so anything that's like a 15 grams of a fast acting carbohydrate, that's what you're going to reach for. Other things I have on here, they have hard candies, graham crackers, honey, anything like that that's going to bring your sugar up. So typically, there's always protocols wherever you're at, whichever facility, and usually they want you to like document, hey, I checked their sugar at this time, I gave them this to eat or drink, and then 15 minutes later I came back and I checked them again. So in 15 minutes, if they were still low, you could give them more stuff to eat or drink. That's totally fine. And then check them again in 15 minutes. So you always check in 15-minute intervals, regardless if you think that's going to be better or not at that time. You always check at that point. Then let's go back to that other situation. So say you have someone who has a really low blood sugar, like maybe they're 22, you know? Can you imagine having a 22 blood sugar? So maybe they're that low and they're not responding to you at all. So you can't safely get them to eat or drink anything to get their sugar to come up. So what are you going to give them?
Would you give them dextrose?
Yes. So you could do D50. So that's what dextrose is, D50. And typically it's in your Pyxis machine. So you would get it out and it comes in a box like this big. And it's already like preloaded and everything. It has this humongous needle on it. But anyway, you get that out, and typically you don't give the whole amount. You give half of that. So I'm trying to remember what the box says now. It's like something like 25 grams is what you would be giving. So it's like half of the normal amount. So when you give D50 in someone's IV, this is just like pushing sugar in their IV. So the bad thing about this is it's going to cause their sugar to spike up, and they can have like another decrease again afterwards. So it will usually help pretty quickly, especially in the IV. So typically you'll see, some good results from this in the next, 10, 15 minutes after you give it. However, you can't kind of prevent some of those crazy spikes. Whereas if you were giving oral stuff, if they were awake enough to take that, then their sugar would stay kind of even keel more. So you'd always prefer to do the oral stuff, but sometimes you don't have any other choice and you have to do this route. What's another thing that you could give other than D50?
You do a shot of glucagon?
Yes. And glucagon comes in a bunch of different forms. So it just depends on where you work at and what form they have. So glucagon, you could do 1 milligram of it. You can give it IM. You could give it sub-Q. And then, when you do this, it's going to take a little bit longer to work than the IV D50 would, right? So typically, you're probably going to have to wait a good 25 minutes or so before you see some good results from this. So even though you're rechecking their sugar every 15 minutes, you may not see good results just yet because it just takes a little bit longer because you're giving it a different route. Now you can give this more than once, so you could repeat it in 15 minutes if you had to. So what glucagon does is it prevents blood glucose levels from dropping to a dangerous level by stimulating conversion of stored glycogen to glucose in the liver. Now, another bad thing about, going back to the D50 for a second, another bad thing about D50 is because you're basically pushing like sugar into their IV, you can make someone's IV go bad really quickly. So if they have a peripheral IV, it's almost 9 times out of 10 it'll go bad after you push that. So some of the things that they might complain of afterwards might be pain at the injection site, And sometimes they'll even complain of headache after you treat them with that. D50 is very irritating to the vein, so again, it can make your IV go bad. So because, if you give someone D50 or glucagon, either one, if you give one of those things, you always want to follow it up later on with a concentrated source of a carb once they're with it enough to take that in, because it'll help prevent reoccurrence of another hypoglycemic episode. Because again, with these, you're causing this big spike in your blood sugar, but it won't stay up for forever. It'll come back down. So if you give them some kind of source of a carb, it's going to help keep them more even keel so that doesn't keep happening. Does that make sense?
Yeah, makes sense.
Okay. Okay, so some other complications that maybe you wouldn't be thinking about. So if you have diabetes for a long period of time, it can cause hardening of the arteries. So and this kind of explains it a little bit in here. It says you can get atherosclerosis. It makes your vessels hard from all the glucose that sticks on the proteins of the vessels, and it forms plaque in there. So these people are at really high risk for heart disease and stroke and hypertension, neuropathy, that poor wound healing like we talked about earlier, the eye problems with the diabetic retinopathy, and then also they're at high risk for infection. Okay, so this is where we start getting a little bit into DKA. So you guys need to write down some things to make you be able to pick this out compared to other things. So we're going to talk about two things here, DKA, and there's something called HHNS. And they're similar, but they're different. So you need to pick out what's different about them so that if you have a question, you'll be like, oh, that's this one, So just kind of pay attention a little bit so you can do that. So with DKA, so this is diabetic ketoacidosis. So there's three main causes for this. So the first one would be, hey, maybe I missed a dose of insulin. And maybe that's why I went into this. Second cause would be illness or infection. Maybe, who knows, maybe you got coronavirus and that set you off and put you into this. Who knows? And then the third thing would be undiagnosed or untreated diabetes. So remember I said earlier that sometimes when people go into the hospital and they have an episode of DKA, that's the first time they've ever had this problem, and that's what, that basically diagnosed them with diabetes. That may be their initial manifestation of diabetes. So those three things are your main causes of DKA. Okay, so what I want you to know about this is that this is going to mainly happen in type 1 diabetics. Doesn't mean that you can't see it in a type 2, but generally it's more type 1s than anyone else. So that would be something that's significant for you to remember. Other things, with this, you're always going to have really high blood sugars. So your blood sugars are going to be greater than 300 for sure, easily, and probably way higher than that even. Okay, so I'm going to read to you something, and I want you to just listen for a second and see if it makes sense to you. So going back to the pathophys thing that we talked about earlier. So when DKA happens, you have an absence or inadequate amount of insulin. So you don't have enough insulin to take the glucose into the cells to give you energy, right? So because this happens, the amount of glucose entering into the cells is decreased. However, you still have release of glucose by the liver. That's going to increase because it senses that your body's having this issue. So it causes increased, secretion of that. And so now you're going to have hyperglycemia. So in your vessels where your blood is flowing, you're going to have more glucose in your blood. So the other things that are happening along with this, your body sees this and it tries to control it through your kidneys. So it starts to excrete glucose along with water and electrolytes. So remember we said that you start to urinate more during an episode like this? So you're getting rid of a lot of fluid. So you're going to be very dehydrated with this. You're going to not only not have enough fluid on board because you're excreting all of this water, but you're also going to have really messed up electrolytes because with the water is going your electrolytes. So anyway, so you would also see a deficiency in the breakdown of fat. As a result, free fatty acids are converted to ketone bodies. So then this person would have ketone bodies as well. These are acids and cause metabolic acidosis. So again, you would see that along with this. I don't know if you remember back when last term when we talked about metabolic acidosis. So this is synonymous with DKA. So again, with this, just think, okay, this is someone who is type 1 diabetic. They're going to have a really high blood sugar. They are going to be really dehydrated and have messed up electrolytes when they have this. They can also go into metabolic acidosis, and they're going to have ketone bodies. So those are significant things about DKA to remember. How do you think we treat someone with DKA? What would we do for this?
I mean, you give them insulin, right?
Yeah, what kind of insulin?
That is a good question.
So we're going to give them regular insulin. Because remember back when we talked about the insulins, we said regular was the only one that you could give in the IV. So this person is always going to be in the ICU when they have DKA. In the ICU, they're in there because you're doing so much for them constantly to get them back under control. It's just a lot of care. So they have to be in the ICU. So we're giving them IV insulin. It's going to be regular insulin every time. It's never going to be anything other than that. So when you get this from pharmacy, it comes in a bag. It's like a small little bag. It'll be hooked to the IV fluids. You'll be giving this continually. And you're going to be checking their blood sugars constantly, right? So we're going to be monitoring that to make sure they're coming down. What else would we be doing to treat this person? No thoughts?
I mean, you'd be monitoring their ABGs, right?
Yes.
And
What
you'd
are-
be
What are we going to do for that ABG though? So it's metabolic acidosis. We have acidosis going on. So how do we fix acidosis? So you know how when we talked about that stuff last term, we talked about bicarbonate, right? So we have acids and we have bicarb, with our ABGs when we were talking about that. So if something is too acidic, we want to give bicarb to kind of counteract that, right? So it's not uncommon to see someone get bicarbonate who is in DKA. And sometimes you'll see it given in IV fluids. So you'll have IV fluids that have that mixed in with it. So that may be something that you see done. This person's very dehydrated, right? So we need to give them IV fluids. So that's super important. That's part of our treatment of this. So what do you think we would give at first? Remember back when we talked about the pathophys here of this, we said that you have this osmotic diuresis going on, right? So all of this fluid is getting pulled out of the cells into the outer part of the fluid there, right? So out, the fluid's out of the cells. So which thing is that when you think back to isotonic, hypotonic, hypertonic? So when fluid is being pulled out of the cells, we have too much fluid outside of the cells, not enough in. So we have hypertonic things going on right now. So our cells are shrunk up, right? So when we give fluid then, we're going to give hypotonic fluid at first to fix this. And remember when we talked about that, we said the hypotonic fluid would cause that fluid to go back into the cells to hydrate those cells up, right? But we don't want to keep them on hypotonic fluid for too long. So we're going to keep a close eye on this with our labs that we draw to see when that's starting to get better enough that we could switch to a different fluid, right? So the only reason we're doing hypotonic fluid is to get some of that fluid out in their outside circulation pulled back into their cells to hydrate those cells. If we left them on hypotonic fluid, what could happen?
Their cells would be dehydrated?
No, we're rehydrating them
Oh,
right
I'm
now
sorry.
with that. So if we left them on hypotonic fluid, what would happen?
Then they would burst.
Correct. So that's
Cell
why
lysis, I think.
yes. So that's why we don't leave them on that kind. So you have to watch your labs, to see if that is fixed enough, and then you would stop that kind of fluid and put them on probably an isotonic fluid afterwards. So you'll see a fluid change every time in this type of patient. So they'll start out with hypotonic and then they'll go to isotonic fluids. Does that make sense or no?
Yeah, makes sense to me.
You're the only one that's talking to me, so I don't know if anyone else is having an issue or not. But
I know, I don't know why, I guess no one wanted to be in lecture.
whatever. At least you'll know it. Okay, so anyway, that's kind of some of the things that we do to treat that. And then once their blood sugar gets down to a certain level, we'll take them off of the IV insulin and then we'll put them on just sub-Q shots of insulin. And so at that point, usually they're better enough to come out of the ICU and go to a different floor. So a couple other things that I just want to point out real quick before we move on. With DKA, remember you can have Kussmaul breathing with that. And then also that acetone smell to your breath. Those are significant with DKA. So usually you don't see that with other things. In here, under signs and symptoms, it also talks about you can have nausea and vomiting associated with this, excessive thirst and stuff like that too, which makes sense because your sugar is really high, Now, I can't, for some reason, you guys don't hear sound when I try to play video on here. So I did post a video, which let me stop sharing for a second so I can show you what I'm talking about real quick. I want you guys to make sure you go watch this because you'll understand this way better after you watch it. So this is under modules. You guys can go see this, but it's this very bottom one. And it's real short. It's only a couple minutes long. But basically, this kid here was admitted into the ER with DKA. And this doctor is filming him, and he is just trying to tell you and show you what Kussmaul breathing is like. And he tells you about, like what brought this kid in, and they showed the labs, and it's just crazy. So you need to watch that. That's a good video to look at. All right. Okay, so that's DKA, and then the next thing is our HHNS. So this is hyperglycemic hyperosmolar non-ketotic syndrome. Okay, so that's a mouthful, isn't it? So this one is very similar to DKA. There's a lot of things that happen just like DKA, but it doesn't go to the same extreme. It's a little bit different. So with this one, this mainly happens in type 2 diabetics. And remember we said type 2 diabetics are usually on the older side. They're not usually real young. A lot of times you'll see older adults who have HHNS. So it's not uncommon to see someone who's older like that have it. So what happens with this is this person is going to have an episode of hyperglycemia, just like you would with DKA. Their blood sugar is going to go even higher than someone with DKA. So if you have the option, hey, is this DKA or is this HHNS? Look at the blood sugar, because if it's like really, really high, it might be this. Also look and see if in the question it says if it's a type 1 or a type 2 diabetic, because that'll help you differentiate. Can you guys still hear me?
Yeah.
Okay. Someone's trying to chat me something and I can't see what they're saying. Is there?
I just said I'm gonna have to get off here. So
Oh, okay.
I gotta take my son somewhere. So that's all I was saying.
That's all right.
All right.
Okay, so with this, you're basically going to have a really high blood sugar, and some of the symptoms that you're going to have are real similar to what you would see with DKA. So you're going to see that they're very dehydrated. They're going to have lots of thirst because they're hyperglycemic. But the thing that kind of would help you pick this out would be the mental status changes. So they have like neuro things going on, and that's not something that you typically see with DKA. This is more this. So typically with this condition, you're going to see it's older adults, and usually they don't come into the hospital right away when they start having things happen. They come when they start seeing the neuro changes. So like maybe their family's like, oh, why are you confused all of a sudden? I'm going to take you in, you know? So usually it's that brings them in. Their blood sugars can be greater than 600, so they're very high. Your insulin level is low here, but high enough to prevent fats from being broke down like in DKA. So like, you know how in DKA you get the ketone bodies and stuff because fats are breaking down? You don't have that in this one, so it kind of stops right then and there. So this is basically a metabolic disorder of type 2 diabetes, and it results from a relative insulin deficiency. And usually it's kicked off by an illness of some sort that raises the demand for insulin. So here, persistent hyperglycemia causes that osmotic diuresis, just like in DKA, which results in a loss of water and electrolytes, just like in DKA. And then to maintain equilibrium, water shifts from the intracellular space to the extracellular space. And so with this person, you're going to see high blood sugar, dehydration, and then their electrolytes are going to be off, and you know they'll have the confusion and the neuro stuff going on. So do you see a little bit of a difference here? I hope.
Yeah.
All right, and then sick day guidelines are the last thing here. And I'm going to tell you right now, you're going to have a few questions on this, for sure. So for this, you have to check your blood sugar every 3 to 4 hours when you're sick. So like if I'm someone who's diabetic, like say I'm type 1 diabetic and I get the flu where I'm vomiting and all of this. So they want me to check my blood sugars every 3 to 4 hours, and also my urine for ketones, because this is going to tell how bad off I am at the moment. They say do not omit or skip your insulin injections or oral medications unless specifically directed to do so by your doctor. So they still want you to take your stuff. If you can't eat or haven't, or you can't keep liquids down or whatever, they say try to replace this by taking in things like Gatorade or Pedialyte and stuff like that. Try and take in something that way. And they say increase your intake of fluids that are high in carbs. So every hour, try to drink something like a sports drink or soup or something like that to keep you doing well. So this is a thing here, the sick day guidelines, because people do this wrong all the time. They will get sick and they just won't take their insulin, and then they'll go into DKA or something, and it's a big issue. So that's why we have this on here. So sick day guidelines, super important. All right, real quick, that was our last slide, but I just want to make sure I talked about everything I wanted to. Let me look through my notes real fast here. If you can, make another small note here somewhere, because I have a couple other things to say before we get off here. So there is a spot in your chapter that talks about like people who have a hard time controlling their glucose, especially type 1 diabetics. A lot of them have a really hard time getting good control. I had a student a few terms ago who was type 1 diabetic, and he was trying to get an insulin pump because he just couldn't seem to get everything under control. So insulin pumps are small. They're externally worn devices that closely mimic the functioning of a functioning pancreas. They contain a small amount of insulin in a little tiny syringe, and it's attached to a long, thin, narrow lumen of a tube and a needle. So the needle would go into like their belly somewhere. They could put it in different places. And then it's kind of nice because they could just put the pump itself in a pocket or whatever. It could be, easily worn. All right, so the patient inserts the needle or catheter into the subcutaneous tissue, usually in the abdomen, and then they secure it with tape or some kind of transparent dressing to keep it in place. This needle or catheter is changed every 3 days. So every 3 days you need to change that. When the pump is being used, insulin is delivered by a subcutaneous infusion at a basal rate. A basal rate means that there's a little bit that gets infused without them having to push a button or do anything. There's just constant little bit of insulin that gets infused. It's set that way. Usually it's about 0.5 to 2 units per hour that you get through that insulin pump. So the thing is, if I'm a type 1 diabetic, and usually it is just a type 1 diabetic who would have this insulin pump, it's never going to be a type 2. So when a meal is consumed, the patient calculates the dose of insulin that they have to cover themselves for with this pump. So they count their carbs from the meal, and they use a predetermined insulin to carb ratio that maybe their physician has set up with them. So maybe, for example, maybe they give 1 unit of insulin for every 15 grams of carbs that they ate. And so if that's the case, 3 units would be maybe what they would dial into their pump for a total of 45 grams of carbs that they ate. So the thing with insulin pumps, they're very good, and sometimes they give really good insulin control to people who are having a hard time, but there are a couple of disadvantages. So there's unexpected disruptions in flow of insulin because of that tubing can get kinked off inadvertently. The battery might be an issue, maybe the battery gets depleted or something. But the nice thing about these two is that you can unhook the pump for limited periods throughout the day. So say you need to go shower or you need to do some exercise or something where you don't want that on, you could take it off for a little bit. So that would be something that you could do. Now, candidates for insulin pumps must have extensive education from their endocrinologist, their diabetes educator, and their dietitian before they're allowed to have this insulin pump. So make sure that you review a little bit about those. Those are in your chapter, page 1477. And then real quick, I just want to mention some, you probably already know this, but I'm just going to say it anyway. There's a little bit on here about foot care. So with foot care, you want to make sure that this person inspects their feet every day. So avoid open-toed or open-heeled shoes. Wear shoes that fit correctly, because there's a lot of people who wear tight shoes or something, and that could be a problem. Don't go barefoot. The best time to perform nail care is after a bath. Toenails are softer and easier to trim then. So you always want to trim toenails straight across and use a file to prevent sharp edges. If you get a cut or a wound on your foot, clean it with mild soap and water, and then gently dry and apply a dry dressing. And then monitor the healing. If it doesn't seem to be getting better, you need to go get seen by someone right away. If you have calluses or corns, you have to consult a podiatrist for that instead of using commercial remedies to get rid of it yourself, because those can cause tissue injury and infection. And then they say to make sure to test water temperature with your hands before using it to wash your feet as well, because again, sometimes they have that neuropathy and they can't feel everything just right. Okay guys, so thanks for staying. I know it's been a long day. So of course I recorded this, so I'll post it when I can here. Just make sure, remember next week you have your diabetes quiz, 10 questions. We start those presentations, so if you have questions about that or anything, you could email me, that's fine. But yeah, just make sure you take this seriously. A lot of people think, oh, I know about diabetes, that's not going to be a big deal. But there's always certain things that you don't know. So like especially about the meds and the insulin and stuff. So make sure you really look at that so that you do well on your diabetes quiz and you keep doing well in the class, okay? And then the hard stuff comes next week when we start getting into the other endocrine stuff. You guys did a good job on the test today. I'm proud of you.
All right, thank you. Have a good day.
All right, have a good
Thank
evening.
Bye.